on. Hold on one second. It's
What happened?
all right. You're now live.
Hi everyone, this is Dr. Jamie Koufman. I've gotten so many questions. Doing this once a month makes sense because what will happen is the topics will declare themselves, and the two topics that have come up the most, besides specific questions about specific treatments or whatever, are chronic cough and trigger foods. So I'd like to talk about those in general, and in doing so, hopefully answer a lot of your questions. Before I do, I want to answer one or two questions about that I think are general. I've had a lot of questions about, how can patients see me? I am no longer seeing patients. Doing virtual consultations, and actually they work out quite well. The virtual consultations, they're a half hour, they're not covered by insurance. I'm in North Carolina. In fact, I've just cut a deal to sell all of my medical equipment. It's in a locker. So I am officially retired from the practice of medicine, but I'm doing consultations, and I'll try to answer as many questions as I can on Facebook. And I again tell everybody to use the blog as though it was a library. It was a resources for you all. So that's the story with that. Koufman Consulting is the site. It's easy to get through jamiekoufman.com. So I'd like to discuss chronic cough with you. I don't know, but of all my books, this book, The Chronic Cough Enigma, is the book that is actually being most reprinted in different languages around the world. And I believe that that's because there's no other content like this content anywhere. And it's content that gives diagnoses or allows you to give diagnoses or self-diagnose even to help you, doctor, and to offer lines of treatment. And I'm going to talk about reflux-related and neurogenic cough. This came recently. I love showing it. It looks like it's in English. You see, I don't know why the light isn't better. The Chronic Cough Enigma. But as it's a Japanese book, and it's really sort of cool to have it in Japanese. And I got it in Polish, and I got it in a few other languages. But anyway, so chronic cough is one of the most common symptoms for which a person seeks medical attention. And the medical definition always was cough for more than 4 weeks. I've seen in different places, even in the medical literature, different numbers of weeks, but it really isn't important how many weeks it is, because most of the people who have chronic cough have been coughing for months or years, so weeks is sort of not important. When you talk about cough, you want to talk about pulmonary cough or cough that results from something in the lung versus non-pulmonary cough. And I'm an expert on non-pulmonary cough. Not that I don't have patients that have lung disease too as a result of reflux, but pulmonary, if you have a lung cancer and and you're coughing because of that. So anybody who has a chronic cough, in my opinion, needs to ask their family. And when I was seeing patients in New York, we insisted that before the patient came to us, that they have a chest x-ray and a TB skin test. And the reason for that is a colleague of mine, one of my fellows, had a chronic cough, multidisciplinary group, and he said the only thing I got out of it was tuberculosis. So multidisciplinary groups don't work. So if you have, it's sort of like if you have one chef who knows what they're doing, replacing that chef with 10 chefs who don't know what they're doing isn't going to get it done. So why this area is such an enigma, and the name of the book is A Chronic Cough Enigma, has to do with two main areas. One is that, as I've mentioned and re-mentioned and probably overemphasized, the gastroenterologists hijacked reflux. They make their money sticking scopes down people, and then they put them on Nexium or Prilosec and say, whatever, see you next year, see you next whatever. So there's not a reflux doctor when it comes to LPR or respiratory reflux. And as I've said before, respiratory reflux is 4 times more common than heartburn and indigestion, and it's usually silent reflux. So we're talking 100 million people. I've put for the first time up today as a blog ear symptoms, and the reason I did that is because there's nobody who said, this is the first time anybody has said reflux causes ear symptoms. And the answer is that the eustachian tubes open into the nasopharynx, which is the nose pharynx, the highest part behind your nose. It actually looks like a puddling area, or a place where a little pond would exist. If you had a reflux event, it would pond right there, and the eustachian tubes get inflamed. So there's no question that there's no doctor for respiratory reflux, and I'm using the new term instead of LPR, but respiratory reflux is LPR. So if it's not in the GI realm, and by the way, many of them pretend there's no such thing, that this valve stops reflux, there's no such thing as LPR, because if I'm right, the GI model of reflux is wrong, and it's a heartburn business model. So the first reason why chronic cough isn't understood very well is there's no doctor, there's no curriculum in ENT or pulmonary on reflux in general and respiratory reflux in particular. The second reason is that there is little appreciation for the connection between the respiratory tract and the digestive tract. And they're connected in 2 ways that are both crucial. Right at the vocal cords is the place where the respiratory tract joins the digestive tract. When stuff comes up, if it goes through your vocal cords, it's in your lungs. But of course, it can come up here and be in any part. So ears, nose, throat, sinuses. And so the respiratory tract is connected. And in fact, in the throat and from in the respiratory tract, this is also the beginning of the digestive tract, right? You chew and you swallow and you get through the upper valve, and then it's in the digestive tract. So you've got respiratory tract and digestive tract in one. The second is going to be more problematic to explain, and that has to do with the vagus nerve. So let me talk about that a little bit, but I'm going to reiterate this 3 times. The June before COVID, I gave the keynote speech at a Boston University School of Medicine event, and it's on YouTube. It's recorded. It's not a great recording, and it's a 40-minute lecture, and it's called The New Field of Integrated Aerodigestive Medicine. It's the future of healthcare, and what we're going to have to do to reduce costs and make this feasible is to take primary care physicians, upgrade them, pay them more. Right now they get $17 for a Medicare visit. That's enough to write a prescription or make a referral. So you need to have a doctor that has your back, that has time to listen to you, that'll work with you. And then that doctor needs to learn integrated air digestive medicine, which is going to be, you'll see one doctor for allergy and asthma and reflux and chronic cough. And so sort of what I do, integrated air digestive medicine. So we don't have that because we've got all these specialists who have divided up the body into little boxes, and all these little boxes don't talk to each other. They don't even read each other's literature when it's appropriate. Almost all of my cell biology work has never been read by anybody because ENT doctors don't read basic science, and gastroenterologists don't read the ENT literature. So getting back to the question of chronic cough, we have a problem with understanding reflux, but we also have a problem understanding the vagus nerve. And you know I'm a non-linear thinker, and I'll try to link all this together before I finish. when you go to medical school, one of your first classes is gross anatomy. And when I took gross anatomy, which was 1970 something, we spent 2 weeks on the cranial nerves. And cranial means that they come out of the brain, cranial nerves. And there are 12 cranial nerves, and most of the cranial nerves do things that would make sense for them to do. All your senses are cranial nerves, hearing, sight, taste, smell. These are all the cranial nerve things. But the 10th cranial nerve is called the vagus nerve. And the word vagus is derived from a Greek word which means vagabond or wanderer. I think it's the second longest nerve in the body. It's certainly the most important. If you cut the two vagus nerves, you're dead. So the vagus nerves run all of the respiratory system and all of the digestive system, with one exception. The diaphragm has its own wiring, cervical wiring. So the bellows that goes up and down. Other than that, everything in the respiratory tract and the digestive tract is vagal. So if I always ask my patients and people when they do consultations, I'm going to give you a test. So tell me what nerve it is. Okay, bloating, vagus. Heartburn, vagus. A sensation of a lump in the throat, vagus. Cough, vagus. Vocal fatigue, vagus. Asthma, vagus. So all of the sensations that you receive, meaning I have pain, I have burning, I have whatever it is, are vagal. And all of the functions are vagal. So as I speak, my vocal cords are being run by the vagus. And so the vagus is the seat of the soul. It's connected with everything. When you go into the brainstem, it's the biggest nucleus, this grand central station. And so the vagus is, people say, well, when I get really anxious, my reflux gets worse. Yeah, it does. When you faint, you get bradycardia through the vagus. It's going vasovagal. So there's no question, when most doctors are talking to patients about different symptoms and the patient brings up something about their neck or something, the doc says that's probably not connected. And my response is, until proven otherwise, it's always connected, unless it's a different disease or a different organ system. So the respiratory system and the digestive system needed to be treated as one. Now, you go to the pulmonary doctor and you have a chest x-ray and you have a negative TB skin test, and then you have a pulmonary function testing, and the doctor says, well, I think you've got asthma, and they put you on an inhaler and a bunch of stuff, okay? Unless you have prolonged expiratory phase, chronic cough and asthma have very little to do with each other. Now, that doesn't say that there are people who have asthma too, but chronic cough is not asthma. Chronic cough is not COPD. But what causes the chronic cough can cause COPD, i.e. reflux. What causes chronic bronchitis, what causes exercise-induced asthma, all of these things, is reflux. So the common denominator between cough and these other things is reflux. Now, what's happening to people? We did a study several years ago that I've never published. And we got permission from everybody, but patients came to me because they had spasmodic dysphonia, and we used Botox in the vocal cords. And I said to these patients, some of you have weak vocal cords, and it's going to change how I treat you. So before I do your first Botox, they had to be Botox virgins. Before I do your first Botox injection, I want to do an actual diagnostic EMG to look at your nerve muscle function. And so we did 40, I don't remember, we did about 50 patients. And it turns out that 40% of people, and by the way, the spasmodic dysphonia is a central neurological problem. It's nothing to do with vocal cord function. But we found that about 40% of the population had focal fold paresis, which is a fancy medical term for partial paralysis of the vocal cords, and it's associated with events that affect the vagus. So I'm going to tell you my story. So I don't have, this is not reflux. I sound like a frog and I can't sing because I have a paralyzed left vocal cord. And some of you have heard the story before, but on Christmas Day, I don't know, 25 or 30 years ago, I was sick with the flu. And a couple of days later, I had no voice. And I examined myself and my left vocal cord was paralyzed. And then I started coughing uncontrollably, like continuously, and I got every reflux symptom with the exception of heartburn. So I was a 50-something, probably. I never had a cough. I never had a voice problem. I never had a reflux problem until I got the flu. So in this book, there is a chapter called Post-Viral Vagal Neuropathy. If you have a chronic cough, you need this book. Not that there's not enough stuff on my there's some really good stuff on the blog, especially when it comes to neurogenic cough, which is not treatment of which is not discussed in the book. The ideas are discussed. So here's what happened. The vagus nerves live right under the lining membrane of the throat, and just like many of you have seen Bell's palsy with the face troops. That's a viral neuropathy, viral sick nerve syndrome. And half the people say, I had a cold and I woke up in the morning like that. And the other half of people say, I woke up in the morning like that. So you don't have to have a clear-cut viral precipitating event that you can recognize to have had a viral neuropathy. So the nerve hits the vagus and the vagus gets sick. Eventually, within 2 years, the vagus is completely healed. It's not going to, no more axons are going to go anywhere. And often there are crossed wires. So I want to explain to you from a sort of a physical sense what neurogenic cough means. I'm going to touch my shoulder and I'm going to say, ouch. Now, we all saw that was a light touch. But if I felt it as an ouch, that was neurogenic. And there are many other examples of neurogenic. Someone has their leg blown off, and 2 years later they have foot pain where there is no foot anymore. That means the way the thing is healed is sending the wrong message to the brain. Now, if you look at a population of patients who come to me with non-pulmonary chronic cough, meaning it's really not the lungs, it's normal chest x-rays basically. About 2/3 of them, let's just say half, have reflux-related and neurogenic cough. And then of the rest, 40% have just reflux and 10% have just neurogenic cough. And why and how is not clear that this has happened. So reflux is the number one cause of cough in you all who have been coughing for 6 years. Neurogenic cough is the second most common. They go together. Reflux is much bigger. If you've got a little neurogenic cough and you have reflux, then the cough goes crazy. And that's why people have intermittent cough. The reflux gets bad, or they have an upper respiratory infection, reflux gets a little worse, and they get cough for 8 or 10 or 12 weeks. And then eventually it settles down and they get another event, or they go on vacation and they drink too much. And so that the neurogenic is lurking in the background. So if you have reflux-related neurogenic cough, reflux symptoms are things like waking up in the middle of the night coughing, perhaps with choking episodes, like a fish out of water, can't get breath in. Productive cough, you're coughing up glop. Wet cough is in general reflux. Dry cough is in general neurogenic. Reflux cough is often with lying down and after meals. Reflux cough can occur when you bend over. If you have reflux cough when you bend over, your lower valve is on vacation someplace far away. So that's a problem. if you reflux and have cough when you bend over. Neurogenic symptoms are rather different. So talking on the phone, chuckling, change of temperature, going into air conditioning, fumes, someone's wearing perfume, someone's cooking toast, and by the way, there's millions of dollars being wasted on studying air pollution for chronic cough. It's just another irritant. My big one when I had this was a jet fuel. So I get on the plane and they turn on the thing and I'd be coughing, for 30 minutes, carrying on. And it would settle down eventually. But jet fuel I still don't particularly like. I can smell it better than other people apparently because I really notice it. So neurogenic cough and talking, singing, particularly on the phone, people will. And it's a dry cough, and it's a cough that wouldn't necessarily be. It's not like you had a reflux event, at 11 o'clock in the morning on a conference call, and so on. And so the other symptoms you may see are vocal fatigue, effortful speaking, and even voice use pain. Now, when I see people who have reflux related, and by the way, I think that this is a real. You can make your own diagnosis. Right here. This is page 14 of this book. Let's see if I can get it there. I'm not good at this. And it asks these questions. And it'll give you what's called the reflux to neurogenic ratio. So if you have just the reflux ones, then it's reflux only. If you got reflux ones and neurogenic, it's neurogenic and reflux. But anyway, that gets me to the point, and I don't want to go on. I want to answer a few questions. That you have to stop the reflux completely. And it's going to be a long and difficult detox program with early eating, with all the things that are suggested. I recommend famotidine. I never use PPIs ever. Stopped in 2014. My patients do great without PPIs. I use Gaviscon Advance, elevation of the bed, and so on. So understand that I can't go through all the bells and whistles of chronic cough today. So I'd like to just spend the rest of the time trying to answer some questions, which will get at the root of it. So Kim says I have a 6-year cough, and my family understands that I do not have COVID. And so understand that COVID is one of the things that can trigger reflux and reflux-related chronic cough. So if you've had COVID and you've got a normal chest x-ray and it's like 3 months later and you're coughing, it's probably reflux-related cough. Remember, any virus can make this happen. And I don't know whether COVID can knock off a vagus nerve or not, but I know it can knock off a bunch of nerves because I had long COVID. And it probably affects the brain stem. So that's why there's so many symptoms in long COVID for some people. I've had a chronic cough for 10 years. This is a really good question. And I have achalasia. Now, achalasia is a specific and uncommon disease in which there's autoimmune attack of the muscles that work the esophagus. So here you have this tube, and at the bottom the valve is still working. But the tube doesn't work, so when people eat, it fills up. Imagine a big funnel with the bottom a little opening blocked up. And then what happens is they lie down and the stuff that they've eaten, partially or incompletely digested food comes up and causes aspiration and so on. I've had a lot of patients who have reflux and achalasia. And for people who have achalasia, you are the ones who ought to buy the expensive bed. You should be sleeping at a high incline forever. You also should be eating at 5 o'clock if you go to bed at midnight. And you ought to be taking Gaviscon. You don't want to have achalasia, stuff filling up. And furthermore, the treatment for achalasia sometimes is to put Botox in the lower esophageal sphincter so the esophagus will not turn out to be this huge bag of potentially aspirated stuff. So once that happens, then you could have free reflux. So long-term use of alkaline water, long-term use of elevation, long-term use of early eating, long-term low-acid, low-fat diet. These are all things. And I've had, I just did a consult, and an old patient of mine is now 93 with achalasia, and it was sort of a refresher course for her. So that's an important one, and just understand that achalasia is pretty rare. Now, that said, I need to mention this, we see a lot of people who have no esophageal function when we evaluate it because of reflux, and we fix their reflux, and esophageal function returns to normal. So just because you've got terrible motility doesn't mean you're going to have achalasia. This one really is an important question. This is from someone called Dare. If high-dose steroids stop my cough and sinus problems, then is it really LPR? The nightmare to me are steroids and antibiotics in many cases. And here's why. Steroids in a reasonable dose will stop anything. You got a cold, you won't have a cold. You got the flu, you won't feel like you got a flu. These are the heavyweight anti-inflammatories. These aren't the steroids that make you muscles. These are anti-inflammatories of the highest order. If here is an ibuprofen, the Empire State Building is the relative difference in effectiveness in anti-inflammatory of prednisone or Decadron. So the problem is that when you take a steroid, let's say you take a steroid pack for a week, 2 weeks later, the reflux is worse. So you end up going on this yo-yo up and down. And so the problem with the steroids is a lot of side effects with long-term use, and I can't get into that. But I never recommend steroids. I recommend diagnosing the reflux and treating the reflux directly. If it's neurogenic cough, I recommend direct treatment of that. Now, there is an article on neurogenic cough on my website. And remember, Jamie Koufman, YouTube, the new field of integrated air-adjusted medicine, 40-minute talk, sort of what I would like to see in the future of healthcare. Who's going to practice IAM, integrated air-adjusted medicine? So that's very important, but I don't, the answer is it probably is LPR, or certainly LPR is a component, but you need a specific diagnosis, and it sounds like you don't have one. You just get a response to the steroids, and that's that. My chronic cough started years ago. I don't know whose question this is. And then went away for a couple of years. Now it's back with thick mucus, bumps in the back of my throat. What could this mean? And the answer is either you had reflux cough and it got better and now some event happened and you cascaded down again, or you had a neurogenic cough. And a lot of my patients have reflux-related neurogenic cough. They'll have these episodes of cough twice a year that last, 8 to 14 weeks on average. So that happens. Here's the specific one, Amy. I had chronic cough for 2.5 years after an upper respiratory infection and went the route of multiple specialists to diagnose the problem. I discovered a certain doctor's wisdom too late after floundering for months. And so she finally is on treatment for reflux-related and neurogenic cough. My very specialized ENT disputed various diagnoses of asthma, reflux, allergies, and said the neurogenic cough and partial paralysis of the vocal cord were the thing. And it's possible. Some people do have just neurogenic. I mean, they're really good eaters, and they eat healthy, they eat early, and all those things. What bothers me about Amy is she said an injection into the proper spot in the neck did it for me. So I'm not a fan of any kind of ablation, a surgical procedure, or injecting whatever, the stellate ganglion. Fix the underlying cause. So the last question I'll answer, because I don't want to go over time, is which doctor will treat neurogenic cough? And the answer is, in my opinion, either your ENT or your primary care physician. After you give them your copy of this book and you tell them I have reflux-related neurogenic cough, and you send them, if they're willing to learn, to the IAM talk. So I'm not sure what the topic will be next week or next month. I'm sorry, first Wednesday, but it'll be based upon the questions that come in, and I will try to leave some time for what I call some of the smaller questions. So anyway, this is Dr. Jamie Koufman signing off. Thank you for your patience, and I hope this was helpful. Chronic cough.